Good evening. Welcome back to an Ask Me Anything with Dr. Twyman. I'm a board-certified cardiologist, and I've been helping people reduce the risk of having a heart attack and stroke at Apollo Cardiology since 2019, but I've been out in practice as a physician since 2005, so not my first rodeo. So tonight we have many good questions. They're always kind of focused on lipids, cardiovascular health, hypertension. Often get some circadian biology, questions and mitochondrial ones as well, which I always enjoy answering for you guys. If you need anything in the interim, always feel free to reach out to me at Apollo Cardiology. So we'll get started here. First question up tonight: what is the best way to mitigate constant EMF and blue light from working 12 to 14-hour day shifts in the emergency room? So I feel for you. I was in this hospital world for many, many years. I was wearing the blue blockers since 2017 in the hospital because the hospital is one of the worst lit places in the entire world. Fortunately, I didn't have any major, medical issues before I left the hospital system. But if you have poor redox potential, you're starting to develop, autoimmune conditions or something where your health is actually at stake. It's the inverse square law. It's getting away from the EMF sources. So it may require a change in job location ultimately. But in the interim, you wear the blue blockers and then do things you need to do to optimize redox potential when you get out of the hospital. So that would be things like sauna, photobiomodulation. So you're optimizing infrared exposure to the cells, as well as grounding, particularly outside, would be starting points that I would look at for mitigating my EMF exposure. Good hydration is also important. So, doctor really wanted me on a statin. I don't know what the cholesterol number is. It just says cholesterol, and there's like a very low digit number, so I think it may be a misprint. Person's 44-year-old female. They're reluctant to go on this class of medication. So it's really going to depend on what is the health of the vascular health. If you have endothelial dysfunction, if you have actual inflammation and plaque in the arteries, no matter where it is in your 60,000 miles of blood vessels, statins are a tool to consider. If there's a let's say side effect while taking the medicine, or you're just really dead set and saying I really don't want to take one, are there other alternatives? There are. Ezetimibe, PCSK9 inhibitors, and Nexletol are the other three classes of medicines that have outcome data, meaning those medicines have been shown to reduce cardiovascular events. But the challenge is some of those are going to be expensive without insurance coverage if you haven't tried previous statin trials. Many insurance companies, or I should say in my experience, insurance companies will not cover PCSK9 inhibitors or Nexletol unless you've previously tried statins or not getting at goal with statins. So I don't, force anybody to take a statin. I always talk about risk benefits of any medications or any supplements people are taking, but it's really based off of the health of the arteries. Okay, what are my thoughts on aspirin therapy? So for secondary prevention, standard of care would definitely recommend 81 milligrams. Take it in the evening time. Secondary prevention means you've had a heart attack, stroke, you have a stent, you've had bypass surgery. You're trying to reduce the risk of having another one. Clear-cut benefit. Primary prevention, where it usually gets a little bit more tricky. If you are younger, your risk of bleeding will likely outweigh the risk or benefit of lowering strokes or heart attacks. But I often will use vascular testing to tell me who's likely in that gray zone, who's more likely to benefit from aspirin. That would include a calcium score that is above 0, a carotid intermedial thickness scan that is not completely normal would lead me towards wanting to use aspirin more routinely for those people, and also patients with elevated lipoprotein little a or Lp(a). All right, question about supraventricular tachycardia while in adolescence. Is it due to too much blue light or electronics? First, there's different variants of supraventricular tachycardia, so we'd have to know more than just SVT. Was it due to Wolff-Parkinson White? Is it paroxysmal atrial tachycardia? Or what is particularly the actual contributor or cause SVT. Sometimes it is non-native EMF. It can be thyroid dysfunction, it can be electrolyte imbalances, but sometimes when it's in adolescents or younger, it's due to an accessory pathway, and that may require an ablation procedure. But people who are having significant heart rhythm issues, they do need to be very mindful that Wi-Fi, Bluetooth, 5G may be more of a trigger to them to kick off more rhythm issues. All right, next question up. High blood pressure for a 55-year-old man. What to test? Exercise is helping, but how to determine the root cause? Great question. This is what we do routinely at Apollo Cardiology. High blood pressure is not a disease, even if it may have a ICD-10 code that insurance will accept for billing purposes. But high blood pressure is a response to something going on in your environment. Often at times it's low nitric oxide levels, can be due to high norepinephrine, adrenaline levels, constricting the arteries, low vagal tone. Often we will do a Vibrant America cardiac panel. There's over 20 genes that can be assessed to see, are you genetically predetermined to have high blood pressure? Could look at plasma renin activity, aldosterone, to see is that a hormonal issue. Often we'll look at an echocardiogram to see is there actual structural damage to the left ventricle. The left ventricle mass is increased, or left ventricular wall thickness is increased, then the high blood pressure is causing damage to the heart, and you want to be more aggressive with your treatment at that stage. Untreated sleep apnea is often a cause for hypertension. So there's hundreds of things that can drive it, so you need to do a kind of comprehensive lifestyle eval to see what might be driving it, but usually you can get to the root cause and get it under control, and the goal is to have a blood pressure less than 120/80. But exercise is excellent. That is always one of the first steps to help. Why is it valuable to eat within 1 hour sunrise? This is mostly if you're leptin resistant. Surely your ancestor hunters didn't do it. Don't know that for sure, but they likely were not leptin resistant, so they didn't have to do it. If you have, quote, pristine glycocalyx, intact vascular endothelium, can ApoB particles create atherosclerotic cardiovascular disease? Yes, possible, less likely in my experience. The glycocalyx is negatively charged. It repels the ApoB containing particles that are also negatively charged. But can it still cause it? Yes. I usually use the analogy that ApoB particles are like shots on goal. The more that you have, the more likely they are going to get into the lining of the arteries. But I always start with optimizing for glycocalyx regeneration if it's suspected that it's been injured, and then repairing pathways if nitric oxide is not optimal. I always talk about that being like a force field. If you keep the force field up, less likely the ApoB particles are getting retained. Could poor vagal tone be a cause for ventricular or any arrhythmias? Yes, it could be. When you have high norepinephrine, it can drive those arrhythmias. If I watch TV right before bed while wearing blue lens blue blockers, what effect will this have? Generally, you're going to have better sleep quality. You want to try to optimize your circadian rhythms by matching what the light conditions are outside. So if the sun is setting at 5 p.m. in your location, like it is where mine is, from 5 p.m. to whenever you go to bed, you want to try to mimic what you would have had access to 200 years ago, which would have been complete darkness or fire. So wearing the red glasses is going to give you the brain signal that it is nighttime. Cortisol levels will continue to decline. Blue light increases cortisol. That's why you're wanting to block it. Cortisol is an alertness hormone. This is why you get a second wind late in the evening if you get too much light exposure. And while you're blocking the artificial light, melatonin levels are able to rise. Melatonin helps you stay asleep, but melatonin essentially is the fuel to repair your mitochondria. But if you have a sleep tracker, you're generally going to notice better sleep metrics if you do it routinely. Next question up tonight is about itraconazole. It's an antifungal agent. It caused high blood pressure and heart rate. And then when the person went to the ER, they got an EKG, X-ray, blood work were normal. Can it be congestive heart failure? I can't give one-on-one medical advice. I can't tell you not to seek medical care if you actually have active symptoms. So you got to talk to your local treating physicians. But heart failure in general is a clinical diagnosis, shortness of breath, exercise intolerance, fluid retention. On exam, the person will have extended neck veins. They may have an S3 or S4 on cardiac auscultation. They may have crackles in their lungs. They may have swelling in their lower extremities or cool lower extremities. They'll have pulmonary vascular congestion on chest X-ray. And then there's a lab called NT-proBNP. If you have high levels of that peptide, then you potentially are in congestive heart failure. But it's a clinical diagnosis. I've personally not seen congestive heart failure caused by an antifungal agent. Can I please remind you what brand of sauna I purchased and if you are satisfied with it? So I have a Relax sauna. It's a one-person sauna, basically a chair that you sit in. Your head's out of the tent, and it heats up very quickly. I'm satisfied with it. I use it a couple times a week in the wintertime, and I like it because it breaks down and folds away for the summertime when you're not needing a lot of infrared light. Previously had a Sunlight and Impulse 3-person. I really like that one. I just didn't have space in my current place to put it back up, so I got a smaller 1-person unit. All right, looks like we got 2 more questions that are pre-submitted. I see a couple other ones popping up in the comments. About what time in the evening is it best for our heart and circulation to go to sleep? Good question. But the body's pretty wise. If you give it the right light signals, it knows when it needs to go into repair. So, generally, you want to be in bed well before midnight. If the sun sets at 5, probably should be in bed by 9, 10 o'clock. If you got your light environment set up right, that's usually going to happen. Sometimes you need a second of what I would consider like a reverse alarm, that you have an alarm to go to bed. So you give yourself at least 7.5, 8 hours of trying to get good quality sleep. And if you go to bed by 9, which is generally around when I'm trying to go to bed, I can't sleep more than 8 hours, so I'm up at 5 a.m. every single day. All right, next question up. High calcium score, but the cardiologist that the person is working with did not send them for an angiogram to look. All right, so the calcium score test is not a test that determines if you need an angiogram or not. Calcium score test is determine risk, and a lot of it is about like tiebreaker, how aggressive you're going to be mitigating that risk. So a calcium score should be 0 forever. If you live long enough, it's often going to become positive, but you want it to be in the latest decades as possible. So if it's in your 60s, 70s, 80s, normal. If it's in your 30s, 40s, 50s, really abnormal. Calcium scores over 400 are considered high risk. Over 1,000 is very high risk. So in the past, when I was still an invasive cardiologist, there are no guidelines that would support this, but if I saw a patient with a calcium score over 1,000, oftentimes we would take them to the cath lab, and in my experience, less than half the time they had any observable stenosis or blockages in their arteries. The calcifications were all in the coronary walls. Think about like an iceberg. The iceberg was below the surface of the ocean, and none of it was poking up. So CT angiograms are not necessary for high calcium scores unless you're having cardiac symptoms such as chest pain, shortness of breath, exercise intolerance, or if you have an abnormal calcium score and you go do a stress test and the stress test is abnormal, then an angiogram may be warranted. But if you're asymptomatic, then you need aggressive treatment for why did you develop such significant plaque in the arteries? How can you support the endothelial glycocalyx and optimize nitric oxide? how can you keep oxidative stress and inflammation low? You can assess that on blood work. And then looking at the lipoproteins to figure out, is it a lifestyle issue? If you're going to do supplements, which usually if you have a high-risk calcium score test, I would not recommend supplements alone. They're generally not potent enough to get you to your targets. And then using oftentimes pharmacogenomics to figure out which medications are likely to work best for you, to optimize your lipoproteins to try to minimize further plaque progression and give you the possibility of plaque stabilization and reversal. And I've definitely seen plaque shrink. I've seen plaque shrink 6% in 2 years if things have been optimized. All right, well, I see a couple of familiar faces here. I think Victoria just popped on, so looking forward to seeing you guys down in El Salvador in a couple of weeks. All right, so I think I saw a couple of questions here. All right, occasional atrial fibrillation at rest, lasting around 45 minutes in a 78-year-old female. So I would recommend that you talk to your doctors about the CHADS VASC score. You plug in your numbers and it tells you what is your risk of stroke. That is the major concern with atrial fibrillation, is how likely it is for you to throw a embolus and contribute to a potential stroke. If your CHADS VASC score is greater than 2, definitely should be considering anticoagulation to lower that risk. Then it's about how symptomatic you are. So if the AFib comes and goes and you're not very symptomatic, there may not be any medications necessary. But if you're in atrial fibrillation and your heart rate's increasing to well over 120 beats a minute, a AV nodal blocking agent such as metoprolol or diltiazem may be recommended to help slow the heart rate down. If the symptoms are very significant, antiarrhythmic agents can often be used. Or if the person can't tolerate antiarrhythmics or they're very symptomatic, then cardiac ablation by electrophysiologist is something to consider. But I always tell patients those are not perfect procedures. Oftentimes you may need the procedure twice, and in the best of hands, it may only be 70% successful. Maybe a little bit more. I haven't kept up with the data in the past couple of years if they've gotten any better at their success rates, but it's not a 100% success rate like most supraventricular tachycardia ablation procedures are. Looks like a lipid question. So high cholesterol at 321, triglycerides 47, which is normal, HDL cholesterol 89. I'll tell you, the HDL cholesterol is really not something to focus hard on. Oftentimes when you have high HDL, it's due to dysfunctional HDL. You don't have reverse cholesterol transport working very well, meaning the HDL can't go into the arteries and clean it out from cholesterol in the arterial walls. So don't hold your vascular risk as considered low just because you have, quote, high HDL. It may not mean much. And then an LDL of 227. So with those numbers of a total cholesterol over 300 and an LDL over 190 milligrams per deciliter, that is potentially consistent with familial hyperlipidemia. They report all their labs are normal. So I would like to confirm that you have normal LPPL2 activity, myeloperoxidase, markers of vascular inflammation, that you have normal nitric oxide markers, so ADMA, uric acid, homocysteine. If you do, good, but I do biophysical testing as well, so looking at arterial elasticity with pulse wave velocity testing, looking at blood pressure, particularly central blood pressures with a device called the ACCOR, looking at endothelial function with a test called an endopat. Those are functional tests to tell you are the arteries stiff or elastic. Then start looking for plaque. You have 60,000 miles of blood vessels, you got to look at it in multiple territories. So in my office, if a patient comes in and they're a new patient and wanting to be screened, we scan the carotid arteries with a carotid intimal medial thickness scan. If they've not previously had a cardiac event, often we recommend they do either a CT coronary calcium score or a CT coronary angiogram to look for plaque in the coronary arteries. We look at a abdominal aortic aneurysm ultrasound. If you have a dilated aorta, that's often due to high blood pressure or atherosclerosis. We do ankle brachial indexes to look at blood pressures in your legs, because if you have an abnormal ABI scan and you have peripheral arterial disease, you're very likely to have coronary artery disease. So looking for plaque is key. Looks like you're doing a lot of good exercise. That's outstanding. Nutrition, I usually tell people you need to know the person's maternal haplotype, so you need to know what kind of mitochondrial engines they have to determine the optimal nutrition pattern for that person. You need to know where they live in the world. Are they eating a seasonal appropriate diet? Are they eating in a circadian rhythm type of pattern? Protein is obviously important for your muscles. So are you getting 90 grams of protein or more a day? Are you eating the amount of carbohydrates you need to maintain the weight that you want to be without spiking your insulin or glucose levels? So there's a lot of moving markers for the nutrition, but there's also a lot of things you need to focus on to optimizing stress and also optimizing sleep to really know what your vascular risk is. All right. Well, that looks like that's the end of the questions that are submitted tonight. So I just uploaded my last 2 IG Lives up to my YouTube channel. The YouTube channel is just drtwyman.tv. So run them through AI agent, and it transcribes at least the main questions. So if you're looking for a particular topic, just search my YouTube channel, type in what you're looking for, and you should be able to find the video that I talk about that topic. There are subtitles on most of the videos as well now. So hopefully that helps people find what they're looking for. Every Monday I'll be here at 6 p.m. Central Time answering the questions live. Best way to submit your questions is look for my story. Usually goes live around 7 a.m. or so Central Time. And then you can plug in your question. And I try to answer as many as I can in the half-hour time that I try to allow for this. So I appreciate your guys' time and attention as always. I do see somebody's asking about kind of a polycardiology question. How would somebody be able to see me as a patient? Great question. I still do have some availability to work with me at Apollo Cardiology. It's basically myself and my team of 2 ladies, Cassidy and Dow. So to work with us, there is an application on my website, drtwyman.com. The application is short, just making sure that we can meet the needs of what you're interested in. Cassidy will have a Zoom call with that individual to walk through the kind of the onboarding process on how to come to St. Louis, how to prepare for the testing that you would have in our office. So I talked about earlier the head-to-toe screening. We do all that in the same day as your visit. Any blood work that we need to obtain from one of the specialty labs, we can send out from our office. The only thing we don't have in our office is a CT scanner. So there's a hospital about 15 minutes away that we refer patients to if they need to do the CT calcium score or CT angiogram and haven't gotten it done in their home city. So if you're interested in that, my website, drtwyman.com, is the place to check it out. Right now, I think I'm booking out about 6 to 8 weeks from now. So if you're interested, go ahead and apply. All right. And then somebody's asking a kind of a one-on-one medical question. I can't really answer that in this this kind of a format. So that would be some better to apply in a kind of a consultation with us, or you'd have to talk to your local doctors about that because I won't have an answer for that particular one. All right, guys. Well, appreciate your guys' time and attention as always, and I'll see you next Monday.